Good afternoon, students. The topic of the lecture is the role of genetics in orthodontics. Any orthodontist have to know how hereditary factors affect dental anomalies and dentofacial deformations. This knowledge is necessary at the diagnostic stage, at defining the complexity of the malocclusion, at the stage of choosing the treatment and preventive care. Studying congenital malformations of the dental system is not only informative and interesting from the embryogenetical aspect, but also very practical. We could prevent these diseases if we knew more information about them. We can find lots of information about etiology and pathogenesis of dental anomalies. A study in Finland, in which 1609 children participated, showed a high frequency of inherited dental anomaly. This study proves that heredity defines child's occlusion and outer factors can only modify it. Grigorieva pay our attention to the fact that from 17 to 21% of dental anomalies are inherited and other ones are obtained due to adverse outer factors. Dental anomaly is a morphological and functional malformation of the dental system due to failure of the embryogenesis. Dentofacial deformation is an obtained progressing change of the structure and function of the dental system due to outer factors. It is known that dentofacial complex appears under the influence of two types of factors. Genotype. This factor tries to implement the program that is already laid down in it, and outer factors. These outer factors can be physiological or pathological. For example, myofunctional state of the facial muscles, illnesses of mother and the child, environmental influence. A newborn baby and children between the ages of 4 to 12 years old are the most vulnerable ones, and outer factors can affect their physical development. However, the share of the genotype constantly increases. That leads to 75% at the age of 13 to 15 years old. The importance of the genetical factor increases with the increasing of the growth rate. Especially at puberty, when the hormones hits regulation of the activity of genes and genetic system that are in charge of normal response to different outer factors. By origin, considering the development mechanisms, all the dental anomalies can be categorized into three groups: hereditary, congenital and obtained. The etiology of malocclusion is a fascinating subject about which there is still much to elucidate and understand. At a basic level, malocclusion can occur as a result of genetically determined factors, which are inherited, or environmental factors. Or more commonly a combination of both inherited and environmental factors acting together. For example, failure of eruption of an upper central incisor may arise as a result of delaceration following an episode of trauma during the deciduous dentition which led to intrusion of the primary predecessor. An example of environmental etiology. Failure of eruption of incisors can also occur as a result of the presence of a supernumerary tooth, a scenario which questioning may reveal also affected the patient's parent, suggesting an inherited problem. However, if in the latter example caries, an environmental factor, has led to early loss of many of the deciduous teeth, then forward drift of the first permanent molar teeth may also lead to superimposition of the additional problem of crowding. While it is relatively straightforward to trace the inheritance of syndromes such as cleft lip and palate, it is more difficult to determine the etiology of features which are in essence part of normal variation, and the picture is further complicated by the compensatory mechanisms that exist. Evidence for the role of inherited factors in the etiology of malocclusion has come from studies of families and twins. The facial similarity of members of a family. For example, the prognathic mandible of the Habsburg royal family is easily appreciated. However, more direct testimony is provided in studies of twins and triplets, which indicate that skeletal pattern and tooth size and number are largely genetically determined. Examples of environmental influences include digit-sucking habits and premature loss of teeth as a result of either caries or trauma. Soft tissue pressures acting upon the teeth for more than 6 hours per day can also influence tooth position. However, because the soft tissues including the lips are by necessity attached to the underlying skeletal framework, their effect is also mediated by the skeletal pattern. Crowding is extremely common in Caucasians, affecting approximately 2/3 of the population. As was mentioned above, the size of the jaws and teeth are mainly genetically determined. However, environmental factors, for example premature deciduous tooth loss, can precipitate or exacerbate crowding. In evolutionary terms, both jaw size and tooth size appear to be reducing. However, crowding is much more prevalent in modern populations than it was in prehistoric times. It has been postulated that this is due to the introduction of a less abrasive diet, so that less interproximal tooth wear occurs during the lifetime of an individual. However, this is not the whole story, as a change from a rural to an urban lifestyle can also apparently lead to an increase in crowding after about 2 generations. Although this discussion may at first seem rather theoretical, the etiology of malocclusion is a vigorously debated subject. This is because if one believes that the basis of malocclusion is genetically determined, then it follows that orthodontics is limited in what it can achieve. However, the opposite viewpoint is that every individual has the potential for ideal occlusion and that orthodontic intervention is required to eliminate those environmental factors that have led to a particular malocclusion. Research suggests that for the majority of malocclusions the etiology is multifactorial, and orthodontic treatment can affect only limited skeletal change. Therefore, as a patient's skeletal and growth pattern is largely genetically determined, if orthodontic treatment is to be successful, clinicians must recognize and work within those parameters. To define a dental anomaly as a congenital or hereditary, to define the genesis of the pathology needs an effort and a consult of other doctors, such as pediatricians, neuropathologists, dermatologists and endocrinologists. The main etiological factors of inherited dental anomalies are mutations of genes and chromosomes and interaction between outer and inner inherited factors. That is why those diseases called multifactorial dentofacial anomalies are usually a manifestation of monogenetic inherited disorders with autosomal dominant, autosomal recessive and X-related types of inheritance. As other illnesses, those are clinically very diverse. Muncke syndrome is the most common syndromic form of craniosynostosis. It is an autosomal dominant condition caused by a point mutation in the FGFR3 gene. The syndrome is characterized by unilateral or bilateral coronal synostosis and a variety of minor anomalies, for example, brachydactyly and cone-shaped epiphyses in the hands and feet, hearing loss, and, in some patients, developmental delay. Unilateral fusion of the coronal suture results in marked asymmetry of the craniofacial region. If untreated, both the symmetry of the maxilla and the mandible become secondarily affected, leading to facial asymmetry in all three planes of space and often with malocclusion in the transverse plane. Unilateral crossbite. We correlate dental anomalies with some chromosomal diseases as Down syndrome, trisomy 18, trisomy 13, Klinefelter syndrome, XYY syndrome, Turner syndrome and XXX syndrome. Turner syndrome can be easily diagnosed from the first days of life, sometimes even before birth. The child is underweight. There is a lymphostasis of the lower and upper limbs, no hair on the neck. During the first year of life the child is stunted, but being stunted becomes noticeable especially at the age of 9 or 10 years old. For a mature patient, being short is the most characteristic feature of this disease. The height of an adult patient is about 145 centimeters. Patients who struggle with Turner syndrome may have a short neck with a webbed appearance, more than 60%, a wide rib cage, 60%, X-shaped deformation of the legs, 56%. Girls with Turner syndrome have underdeveloped ovaries, resulting in a lack of monthly periods and infertility. Other features that may have developed in the womb include heart condition, kidney abnormalities, skeleton deformations and skin conditions. However, the intellectual development of those patients is normal for their age. Their bone development, both in chondral and periostal, failed. Girls with Turner syndrome have early teething. Their permanent teeth got short roots. Those patients have idiopathic resorption of the teeth, microdenture. This chromosomal mutation even leads to decreasing tolerance to teeth decay. 82% among these girls struggled with caries. Causes of congenital abnormalities: extragenital diseases of the mother, acute INFESTIANs. Toxicosis in pregnant women, a big size of the fetus in comparison to little amount of the amniotic fluid, abnormal fetal presentation, alcohol and drug addiction, smoking cigarettes. Using drugs that capable of acting as teratogens, radiation and chemical substances affecting birth injury. Inherited and congenital dental anomalies are caused by failure of the craniofacial development at the antenatal period. There are 5 main steps of the craniofacial development of the fetus. The implanted blastula forms 3 germ layers. Development of the neural tube and initial formation of the oral part of the pharynx. Migration and interaction of the cells of the neural fold. Neural crest. Formation of the organs. Formation of the pharyngeal and branchial arches, primary and secondary palates. Final differentiation of the tissues, the muscle, skeletal and neural tissues. Some specific deviations from the norm in the craniofacial development can be detected on the first and second stages of formation. For example, the usual appearance of the fetal alcohol syndrome fetus is caused by underdevelopment of the neural plate due affection of high concentration of ethanol. But the biggest amount of dental anomalies appears at the third stage of craniofacial development during migration and formation of the neural fold. There are not only congenital but also inherited cranial dysostoses caused by malformation of the neurocranial cord, which develops into the brain, middle part of the face. First and second branchial arches and dental system. For example, failure of the neural fold cells migration leads to craniofacial dysostos, Franceschetti syndrome. This congenital syndrome is about underdevelopment of the upper and lower jaws due to lack of mesenchymal tissue. Moreover, these patients struggle with malocclusion, facial asymmetry, abnormal shape and size of the auricles. The most frequent congenital anomaly is clubfoot. The second most frequent congenital anomaly is cleft lip and palate. Less frequent cleft facial structures, the same as more frequent ones, appears at the fourth stage of development. Cleft lip is caused by improper fusion of the medial and lateral nasal processes during week 6. Due to unfavorable factors, which affected the fetus. At the age of 3 months of gestation, the processes, which form the facial skeleton and upper jaw, do not grow together. Cleft lip, alveolar process and palate are very complex and most frequent anomaly. Different studies show that 30% to 50% present of children with clefts inherited those from some family members. The highest chance of inheriting a cleft is inheriting a bilateral cleft upper lip, alveolar process, soft and hard palate, about 36%. When evaluating a congenital malformation in a child, it is crucial to clarify whether it is an isolated malformation or part of a syndrome with other, perhaps uncovered, organ manifestations. The prognosis for an isolated malformation is often favorable, and the recurrence risk is low. Conversely, the prognosis for malformation syndromes is often grave, especially if the central nervous system is involved, and the recurrence risk may be as high as 25 to 50%. An isolated primary malformation may cause a sequence of structural defects. For example, a child with hypoplasia of the mandible, primary malformation, may also have cleft palate, secondary malformation or deformation. Because the normal-sized tongue did not allow for normal closure of the palate during fetal development, as seen in Robin sequence. Craniofacial anomalies can be formed at the final stage of development of the facial structures of the fetus. Craniosynostosis is premature fusion, most often prior to birth, of one or more cranial sutures of the calvarial vault. In addition, sutures of the cranial base, the orbits, and the maxillary complex may be involved. Some syndromes with craniosynostosis even have fusion of the synchondroses of the cranial base. Craniosynostosis is a serious abnormality of infancy and childhood requiring proper diagnosis and treatment. It can be isolated or syndromic, and proper diagnosis is essential for optimal patient care. Mutations in at least 8 genes are unequivocally associated with Mendelian forms of syndromic craniosynostosis. Crouzon syndrome has an autosomal dominant inheritance. Around half the cases are caused by new mutations, and, similar to Apert syndrome, new mutations are of paternal origin. And their risk of occurrence increases with increasing paternal age. Activation of FGFR2 signaling in Crouzon syndrome probably results in premature osteoblast differentiation and fusion of craniofacial sutures and synchondroses. The syndrome includes craniosynostosis, hypertelorism, ocular proptosis, and midface hypoplasia. Craniosynostosis is most often apparent at birth, but it may also develop during the first few years of life. Variable expression characterizes Crouzon syndrome even within the same family. The variable expression can most likely be explained by the fact that the pattern of fusion of sutures and synchondroses may vary both in location and in timing. Individuals with mild expression of the phenotype may remain undiagnosed although they have one of the known mutations in FGFR2. Skull shape is most often brachycephalic because of bicoronal synostosis, but dolichocephaly secondary to sagittal synostosis has also been reported. The craniosynostosis may lead to increased intracranial pressure, and early neurosurgical treatment, within the first year of life, is most often required. The maxillary hypoplasia in all 3 planes of space contributes to the ocular proptosis, and it also may result in a compromised nasopharyngeal airway with risk of sleep apnea. In addition, maxillary hypoplasia leads to severe crowding, delayed eruption and ectopic eruption of the teeth, and most often to severe malocclusion with mandibular overjet, frontal open bite, and bilateral cross bite. The MSMSU Orthodontics Department classification of dental anomalies, teeth anomalies. Abnormal shape of the tooth. Abnormal structure of the hard tissues of the tooth. Abnormal color of the tooth. Abnormal size of the tooth. Macrodentia. Microdentia. Abnormal mount of teeth. Hyperodonta. Hypodonta. Abnormal eruption of the teeth. Early eruption. Late eruption. Retention. Abnormal position of the tooth. Vestibular. Oral. Mesial. Distal. Supraposition. Infraposition. Tortoanomaly. Axis rotation. Transposition. Anomaly of the dentition. Abnormal shape of the dentition. Abnormal size of the dentition. In the transversal plane, constriction and expansion. In the sagittal plane, lengthening and shortening. Failure of the teeth sequence. Asymmetrical position of the teeth at the dentition. Failure of teeth interaction, crowded teeth or gaps between teeth. Jaw anomalies. Abnormal shape of the jaw. Abnormal size. In the transversal plane, constriction and expansion. In the sagittal plane, lengthening and shortening. In the vertical plane, increasing or decreasing of the height. Mixed pathology. Misalignment of the jaw parts. Misalignment of the jaw towards one another. Person's classification of dental anomalies. Malocclusion of the dentitions. In the side section. In the sagittal plane, distal or mesial occlusion. In the vertical plane, disocclusion. In the transversal plane, vestibular occlusion, palatal occlusion or lingual occlusion. In the frontal section, disocclusion. In the sagittal plane, due to protrusion or retrusion. In the vertical plane, vertical incisive, no overlap, deep incisive, deep overlap. Deep incisive occlusion. Malocclusion due to couples of antagonistic teeth. In the sagittal plane. In the vertical plane. In the transversal plane. The ICD-10 classification mentions such dental anomalies as microdenture, macrodenture, schisses, synodenture and schissodenture, dens invaginatus, adamantoma, bull tooth, and other size and shape abnormalities. Macrodenture is a condition that defines two big teeth. It can be categorized into three groups. General macrodenture, all the teeth are bigger than the normal ones. Comparative general macrodenture, some teeth are slightly bigger than normal. Isolated macrodenture, only one tooth is bigger than the normal teeth should be. There are comparative and absolute macrodenture in orthodontics. Macrodenture can be detected during a dental checkup and using analysis of diagnostic records. Tooth size analysis is carried out by measuring the mesiodistal width of each permanent tooth. A standard table is then used to compare the summed width of the maxillary to the mandibular anterior teeth and the total width of the all upper to lower teeth, excluding second and third molars. Macrodenture can be a condition by itself, but also can be a feature of some inherited diseases or congenital conditions with many other symptoms. Microdenture is medical term to too small teeth. It can be categorized into three groups: general microdenture, comparative general microdenture, isolated microdenture. General microdenture is a condition when all the teeth are developed as usual except their size is too small. General microdenture can be a condition by itself, but also can be a feature of some inherited diseases with many other symptoms such as pituitary dwarfism. Comparative general microdenture is a condition which described as a combination of teeth with normal sizes and too small teeth. Moreover, there are more mandibular teeth that are too small than the normal ones. Isolated microdenture is a situation when a patient have only one little tooth and the other teeth are normal. The most frequent situation is microdenture of the lateral upper incisor or microdenture of the third molar. Microdenture can be a condition by itself, can be in combination with some other dental anomalies, but also can be a feature of some inherited diseases or congenital conditions with many other symptoms. The Europoid, Caucasian, population frequency of isolated microdenture is 1 to 2%. Apparently, isolated microdenture is related to a mutation of the PAX9 and MSXI genes. Fused teeth are a developmental anomaly involving the union of two dental germs at the crown, root or pulp. This pathology appears as increased mesiodiastal width of the tooth crown. At the same time, the lateral incisor is absent due to his fusion with the medial incisor. The population frequency of this condition is 0.5%. Bifurcation, Schistodentia tooth is an abnormal double tooth, which develops due to a split of the tooth germ. It is more usual to happen with the upper incisors than the lower incisors. The population frequency is 0.5%. Tooth invagination is the same as dens in dente. Tooth invagination is an odontoma inside the tooth, which appears at the early stage of development of the epithelial diaphragm. It can happen either as an isolated malformation or in combination with other abnormalities as a symptom of some inherited conditions. Probably isolated invagination is a multifactorial condition. In some cases this condition appears due to an autosomal dominant mutation. The population frequency of this condition is 3%. In the OMIM data there are two monogenetic inherited diseases that are correlated with tooth invagination. The first one is taurodontitis. That comes out as a combination of microdenture and tooth invagination. This X-linked inherited disease manifests as a generalized microdenture. Taurodontitis of the first molars. Those teeth got enlarged elongated pulp chamber and short roots, and multiple tooth invaginations. Other illness with tooth invaginations has autosomal dominant type of inheritance. This condition is called dens in dente and palatal invaginations. Moreover, we have to mention many conditions that manifest as an abnormal size and shape of the teeth disease as Hutchinson teeth, Fournier teeth and Pfluger teeth, spiked teeth, fish teeth. Abnormal amount of teeth is too much or too less teeth. Teethogenesis, oligodentia, hyperdentia, adentia, is congenital absence of one or many teeth. One of the most frequent human malformation. The Europoid, Caucasian, population frequency of permanent teeth hyperdentia is 4.5 to 7.4%. The most common situations are missing lateral incisors, second premolars and third molars. Congenital absence of the third molars is so common that many agenesis research articles do not mention those as a case of agenesis. Adentia is a malformation of the placode stage and the bud stage of tooth development. The sex ratio is 2 to 3. 35% of this pathology is family related. The concordance of monozygotic twins is 89%. Familial teethogenesis got autosomal dominant, autosomal recessive and X-related types of inheritance. However, sometimes the type of inheritance cannot be defined. In the majority of cases agenesis have multifactorial etiology due to the action of many genes. This condition can appear in association with some hereditary disorders as well as on its own. Just absence of a tooth or a few teeth is more likely to happen in a case of hyperdentia. For syndromic oligodentia is more usual to miss the permanent teeth. The population frequency of this pathology is 0.07 and 0.13%. On this slide we see a few photos of patient with hyperdentia. Also, we can notice on the upper right picture microdenture of the 12th tooth. On this slide we see an orthopantomogram of a patient with multiple hyperdenture. Hyperdenture is having supernumerary teeth. Hyperodontia can be single and can be multiple. This pathology appears due to malformation, excess activity of the dental placode. This condition got autosomal dominant and X-related types of inheritance. Supernumerary teeth usually have an abnormal shape. Those teeth can be malposed or take a place at the dental arches. The most common supernumerary teeth are upper incisors, premolars and upper third molars. The population frequency of temporary supernumerary teeth is up to 0.1%. But for the permanent supernumerary teeth is 1 to 5%. The majority of cases of supernumerary teeth is sporadic. The amount of familiar cases is 30%. Here we see a 10-year-old patient that is diagnosed with 18 supernumerary teeth. Those 18 supernumerary teeth were extracted at the hospital and the patient got removable appliances that stimulated the teeth eruption. After 7 months 12, 42 and 43 erupted. Multipay hyperdenture is common among patients with cleidocranial dysplasia. On this slide we see a patient with cranioclavicular dysostosis with 4 mesodons, supernumerary incisors. Another disease, which manifests with supernumerary teeth, is Gardner's syndrome. This disorder's symptoms are supernumerary teeth, intestinal polyposis and osteoma. Early eruption and late eruption of teeth, retention, are both symptoms of many hereditary diseases, chromosomal, monogenetic and multifactorial ones. Garayev conducted a study about the importance of inherited factors and the impact of inbreeding on frequency and structure of dental anomalies. He involved clinical genealogical analysis, segregational analysis and lineage of a proband's families with abnormal amount, shape, size of teeth, teeth with enamel growth deficiency. Garayev also conducted a study about diastema. He examined a big family of 95 relatives, 29 of them, its 43.5%, had diastema. After studying the data about 4 generations and the vertical transmission of the anomaly, the scientists made a conclusion. Both genders are exposed to this dental anomaly and the general penetrance of this genetic condition is 92%. Clinical genealogical analysis of frontal crowding of teeth proband's families shows that at least one of the proband's parents had the same abnormality. This means that this dental anomaly have autosomal dominant type of inheritance and is exposed to both genders. The same type of inheritance is typical for abnormal position of the teeth in case the probands have distal or mesial occlusion. However, open bite, cross bite and overbite have multifactorial type of inheritance. V-shaped jaws have codominant type of inheritance. It is known that in cases when dental anomaly is just a symptom of a complex inherited disorder, this dental anomaly have chromosomal autosomal recessive type of inheritance. For proving dominant and recessive hypothesis of inheriting adentia, 36 proband's families with adentia were examined. The scientists made their family trees for 3 generations: children, parents and grandparents. In addition, this anomaly is spread both vertical and horizontal directions at the family tree. Both genders are included. 14 cases of partial adentia have vertical spreading, which means that is autosomal dominant type of inheritance. 22 cases of partial edenture have horizontal spreading with no dental anomalies of the proband's parents, which means that is autosomal recessive type of inheritance. In all of 22 cases, the proband's parents were related by blood. Moreover, the author have found out that enamel hypoplasia have two ways to inherit. The enamel hypoplasia in a form of points is autosomal dominant. The enamel hypoplasia in a rough shape is autosomal recessive. Abnormal eruption of permanent teeth and spiked teeth have the same autosomal dominant type of inheritance. I have made a few tables to help the medical genetics in the consultation about dental anomalies. He made a table about types of inheritance for dental anomalies. In addition, he made a table of population and intrafamilial frequencies of dental anomalies. He calculated the intrafamilial inbreeding ratio for every single dental pathology. According to modern ideas, malocclusions are multifactorial anomalies and appear due to complex interaction of inherited and outer factors. What occlusion type would have the patient depends on many inner and outer factors. However, we can define the pathogenesis of dental anomaly as a process in which happens some change and damage to the growth zones of dental structures. Some outer and inner factors affect this process. Child's dental anomaly due to stable pathogenetical mechanisms got a very high-level population frequency. These mechanisms are related to genetical factors. Deterioration of children's and women's health. For example, there is a high-level frequency of pregnancy complications, birth trauma. There are people who struggle with chronic diseases. The increase of birth defects and inherited disorders is intimidating. Normal occlusion and malocclusion got three morphofunctional features: dental, muscular and articular. So, we might not forget about these features when we plan our orthodontic treatment if we want stable results. Dental anomaly appears to be caused by not only genetical reasons, but also ecological reasons. We categorize dental anomaly into three types: inherited dental anomaly, congenital dental anomaly and obtained dental anomaly. These anomalies can be post or prenatal. Genealogical analysis proves that the amount of teeth, their size and shape, disproportional jaws and teeth are inherited. Any dental anomaly is a so-called congenital anomaly and is caused by serious malformation of the embryo. Moreover, many negative outer factors and bad habits lead to development of many different dental anomalies at any age. There are about 16 risk factors for a dental anomaly. Every child with normal occlusion has been exposed to 2.05 risk factors. Every child with distal occlusion has been exposed to 2.73 risk factors. Every child with mesial occlusion has been exposed to 2.71 risk factors. Every child with overbite has been exposed to 2.32 risk factors. Every child with open bite has been exposed to 3.44 risk factors. Every child with abnormal dental arches has been exposed to 2.1 risk factors. There are 66.8% distal occlusion will be inherited by your descendants. For mesial occlusion the percentage even higher, it is 84%. the percentage of outer factors affecting those dental anomalies to appear are 34% for distal and 16% for mesial occlusion. For Angale's I-class malocclusion, the effect of outer factor is very important, so the population and intrafamilial frequencies are approximately the same. There are 80.9% dental arches constriction will be inherited by your descendants. For open bite, this percentage is 51.2%. For crossbite, this percentage is 95.4%. Distal gives us information that says that diastema, trema, teeth crowding, abnormal size and position of teeth are autosomal dominant inherited. According to the author, distal occlusion have autosomal dominant and multifactorial inheritance. It means that children with dental anomaly need a geneticist's consult. Perhaps realization of the genetical program depends on the combination of some outer conditions affecting the organism. Dental anomaly develops due to many adverse factors that the child's body faces during growth and progress. However, it is estimated that dental anomaly is caused by such reasons as respiratory pathology, bad habits, tooth decay, rickets, diseases of the endocrine system and chronic intoxication of the child. Outer factors that influence pathological of normal growth of the dental system could be categorized into three groups: functional factors, factors of disease effect, and ecological factors. Appositional growth at a seam joint depends on functional tension of chewing and mimic muscles. Jaws having different sizes at the sagittal direction is a result of an improper development of the cartilage structure of the maxilla and mandibule. The outer factors: myofunctional malformation, somatic disorders, loss of temporary teeth before the change of teeth, are more affecting the development of dento-alveolar forms of malocclusion. However, for skeletal forms of dental anomalies, hereditary factors are the most important ones. The vertical proportions are more genetically affected than the sagittal proportions. The concept of polygenetic heredity of distal occlusion is already proved. The results of twin studies show that the indicator of importance of heredity is the highest for distal occlusion with incisors retrusion. The concordance for monozygotic twins is 100%. For the dyserotic is 90%. Garayev found out vertical transfer of distal occlusion after deep study of clinical genealogical analysis, segregational analysis and lineage of a probans family. According to the author, distal occlusion have autosomal dominant and multifactorial inheritance. He also shows that inbreeding affects dental anomaly. 36.6% chance that in an inbreed family with distal occlusion heredity a child will be born with an distal occlusion himself. However, population and intrafamilial, without inbreeding, frequency of distal occlusion is 10% and 15% resp. Intrafamilial inbreeding ratio in families struggling from dental anomalies is 25 times higher than population inbreeding ratio. According to this information, we as medical care workers can provide high-quality medical care so patient and their relatives could have the fullest information about hereditary pathology. What the chances that this pathology would develop and what precautionary measures they have to take for not having it. Overbite is considered a modern disease because the already found fossil skulls do not have this malocclusion. Many researchers correlate the occurrence of overbite to reduction of the ramus of the mandible and increase in temporal muscle tone. Moreover, among the reasons that cause overbite we will mention heredity, especially if we discuss blocking overbite. The development of overbite is a result of the total action of the genetical and environmental factors. It means that this anomaly is multifactorial. The vertical interaction of the front teeth is largely genetically determinate. After crossing a certain threshold of a sum of hereditary factors, it leads to development of an overbite. Now, for this point the outer factors become very important. They can improve or worsen the anomaly. The severity of apical resorption of the root, which can develop due to some orthodontic treatment using non-removable dental tools, can also be defined by heredity. The value of genetical factors in this case is from 50% to 64%. Patient with root resorption got some changes in their B gene of the interleukin-1. The vector of jaws development is genetically determined and we need to consider if we do not want a relapse. Genetic counseling is the process where a patient with a genetic disorder or a patient's relatives are informed about its etiology and natural course, about the risk of transmitting it to family members, and about how it can be prevented or treated. It is a communication about prognosis, which is based, ideally, on a precise genetic diagnosis. Similar to management of the patient's genetic disease, genetic counseling can be viewed as management of the family. Since the mutation for a disease may be transmitted from one generation to the next, genetic counseling should be offered before a new pregnancy is considered. This will allow the family to know their recurrence risk and to make an informed choice between their reproductive alternatives, including prenatal diagnosis and pre-implantation genetic diagnosis. The main tasks of the medical biological consult are diagnosing the disorder, defining and explaining the meaning of genetical prognosis to the patients and their families. The main tasks of the medical geneticist are diagnosing, calculation of the genetic risks and reporting the information to the parents. A criterion of a good genetic consult is a well thought out decision. The steps of a genetic consult are: genetic history taking and building the family tree of the patient, examination of the patient and his family, phenotype analysis, matching the available information with databases and medical books, ordering for the patient some checks, tests and other specialists' consults, supporting the family and scheduling the next appointment. Building the family tree is an active process. The doctor asks the family about all the details of kinship in the family. Did anyone had miscarriages? Were there any stillbirths? Who was sick with what illness? Who died from what and how anyone looked like? Phenotype analysis is when the geneticist pay attention to small anatomical peculiarities and details of the body. They analyze the shape of faces, eyes, jaws, organs and tissues at the oral cavity, ears. They analyze the shape of feet and hands. They analyze the shape of skin, nails, hair. Phenotype analysis can really help in diagnosing. However, sometime we do need to explore more. The geneticist can order karyotyping. Other specialists consults and matching the phenotype with some database information. For example, only an ophthalmologist can detect a lens subluxation for a patient with Marfan syndrome. At the second appointment, the geneticist diagnoses, evaluates risks, conveying the information to the patient's family, observation and treatment. In a case of pregnancy, the geneticist will order some prenatal checks and tests. Nevertheless, any geneticist do analyses risks in having sick children. The risk of developing the disease is considered as low for 5% and less, as elevated for 5 to 10%, as average for 10 to 20%, and as high for more than 20%. However, we should realize that there is a huge difference between a high risk of polydactyly and a high risk of heart defect. The final consultation is conveying the result to the family. The geneticist speaks privately with the parent. The geneticist says to the parents, "You can take your time." It takes time to accept some diagnoses. Only the parent themselves can make a choice to have children naturally or adopting a child. Prenatal diagnosis is possible by cytogenetic, biochemical, or molecular analysis of a chorionic villus sample obtained around gestational week 11. Prenatal diagnosis of multiple malformation syndromes with structural defects may be feasible by ultrasonography if the genetic defect is unknown. Pre-implantation genetic diagnosis is feasible by cytogenetic or molecular analysis of a single cell from a zygote of 8 to 10 cells conceived in vitro. After exclusion of the genetic defect, the zygote is implanted in the uterus. The chance of obtaining a non-affected child by pre-implantation genetic diagnosis depends, among other things, upon how many eggs it is possible to fertilize. How many fertilized eggs will proliferate in vitro, and the number of zygotes without the mutations in question. Thank you for your attention.